Good evening, everybody. Welcome. I'm Kate Pickett. I'm Professor of Epidemiology in the Department of Health Sciences and Deputy Director of the Centre for Future Health. And I also sit on the university's Mental Health Research Steering Group. And on behalf of that group, I'd like to offer you a very warm welcome to this evening of talks and discussions marking World Mental Health Day 2020. In a moment, I'm going to hand over to the university's Vice-Chancellor to say a few words, but first I'll just explain a little bit about the format of the evening. We've got 4 speakers for you tonight. Firstly, our keynote, Dr. Kwame Mackenzie from the Wellesley Institute in Toronto, followed by 3 researchers from the University of York. And then at 7:30, we'll bring together all of the speakers to reflect on what's been said and to answer your questions. And we'd like to invite you to submit a question at any point this evening. We welcome questions either relating to a specific point made by one of the speakers or more generally concerning the impacts of coronavirus on the mental health of different groups and the ways that these might be addressed. I'm afraid, however, that none of us can offer any individual advice. If you've got any personal queries or concerns, then we'd recommend that you instead contact your GP or a dedicated mental health organisation such as the Samaritans or Mind. I hope you saw our mental health signposting slides at the start of the event, but we'll also play those again at the end. So to take part in the Q&A, please click on the Q&A button at the ribbon at the bottom of your Zoom window. And that will open up the question and answer panel, the Q&A panel, and you can type your question in there and hit send. Live captioning is available for this event, and if you want to enable that, please use the closed caption option at the bottom of your screen and select show subtitles. And if you get disconnected for whatever reason, you can rejoin the event using the original link that you were emailed. Please also remember that today's event is being recorded, so you will be able to watch it again in a few days' time at youtube.com/YorkIdeas. And please do use #YorkIdeas on social media if that's something you're into. So without further ado, I'm going to hand you over to our Vice-Chancellor, Professor Charlie Jeffrey. Over to you, Charlie.
Thank you very much indeed, Kate, and good evening, everybody. It's a great pleasure to welcome you on behalf of the University of York to what I'm sure is going to be an inspiring and thought-provoking programme, marking World Mental Health Day as an international day for promoting understanding, awareness and advocacy of mental health, but also for inspiring action by our governments and in our communities in support of better mental health. The day was initiated in 1992 by the World Federation for Mental Health and is now championed by the World Health Organization. This day is an important annual event for the university where we get the chance to share our vision of a world in which mental health is valued and promoted, mental ill health is understood, prevented and effectively treated, and people living with mental health problems are free from stigma, discrimination and inequality. The annual date for World Mental Health Day is the 10th of October. We're the 15th today, but however, the official announcement this year declares that World Mental Health Day is not simply a one-day event. And I think that's especially pertinent in 2020 as the current COVID-19 pandemic has transformed our lives and presented governments and societies with extraordinary challenges, especially in the field of mental health. Young people have experienced diminished contact with teachers and friends. Many older people have had to self-isolate and shield. Some have lost their jobs or have had to reduce their hours, while others continue to worry for their livelihoods. All of that has profound implications for mental health, not least for those with existing mental health problems. However, a growing number of studies are now revealing that the effects of COVID haven't impacted uniformly on individuals and groups. And for this reason, this year's World Mental Health Day theme of achieving mental health for all has particular resonance and urgency. In this vein, our aim this evening is to explore some of the effects and implications of the pandemic on the well-being and healthcare of a number of different populations across society and the life course. Several of the talks are going to be delivered by researchers here at the University of York. Mental health is one of our areas of truly outstanding capability. They come from different disciplines and are therefore able to illuminate different facets of the challenges that we see. The university has strengths in mental health research across a number of departments, including the Mental Health and Addictions Research Group in our Health Sciences Department and the interdisciplinary International Centre for Mental Health Social Research led by our Department of Social Policy and Social Work. Our motto is that our research should make a real difference through informing policy and practice, developing new ways of promoting good mental health, to treating mental ill health, and supporting people with chronic conditions to live better. Investing in mental health research and providing mental health support to our students is a priority for the university, and transforming mental health is a key goal of York Unlimited, the university's fundraising and volunteering campaign. Many of us, and I include myself in that, will either have direct experience or will know someone who's experienced disorders such as depression and anxiety. Globally, these affect 450 million people. Yet while mental ill health causes around 25% of the total disease burden in the UK, it receives just 13% of the health budget. But in order to develop effective solutions, we need to understand the causes of mental ill health across the lifespan, the value of different interventions and management strategies at all stages of life. We need more funding to do that. The guiding principles of our research are therefore to ensure that mental health care is effective, efficient, and equitable. And our ambition is to develop and enhance effective preventative interventions and management strategies to reduce the number of people affected by mental ill health and all of its impacts. Through our campaign, we're inviting our supporters to help create PhD scholarships and to support early career researchers across different disciplines in designing and evaluating potential solutions. We're also helping to build the mental health workforce of tomorrow by funding scholarships to support mental health nurses. And we're supporting mental health initiatives here in the City of York through the Mentally Fit York Fund. Please visit our website to learn more about how you might be involved in all of those activities. Finally, let me take the opportunity to wish you and your loved ones well in both the mental and the physical sense in these challenging times. With that, I'm going to hand you back now to Kate, who will introduce our first speaker this evening. Great to have you here. Thanks very much for joining us.
Thank you, Charlie. And I know you have to leave us fairly soon because you have to attend a conference in Mexico virtually later tonight. I was reflecting this afternoon, actually, while I was attending a conference in Italy virtually, whilst also pedaling on my exercise bike and able to turn off my video when I wanted to eat a banana, how actually sometimes it's convenient and a blessing to be able to take part in remote events. I like to think that our keynote speaker tonight, we could have induced him to come to York in normal circumstances, but as he's joining us all the way from Toronto, perhaps we've been fortunate that this is an online event and he's able to join us for the evening. And I'm absolutely delighted to introduce our keynote speaker for tonight, Dr. Kwan McKenzie. He's joining us from the Wellesley Institute in Toronto, where he is the CEO. He's an international expert on the social causes of mental illness, suicide, and the development of effective, equitable health systems. He's an academic and a clinician with over 200 papers and 5 books to his name, and he's received numerous awards over the past 2 decades working to improve population health and health services. Dr. McKenzie is Director of Health Equity at the Centre for Addiction and Mental Health and a professor in the Department of Psychiatry at the University of Toronto. He's a member of the National Advisory Council on Poverty a member of Canada's expert advisory panel on COVID-19 and mental health, and served as part of Canada's delegation to the high-level political forum on the social development goals. And in addition to his academic policy and clinical work, he is a columnist for The Guardian, The Times Online, The Toronto Star, and a past BBC radio presenter. It's a real privilege to have him join us this evening, and I know he's going to be a great speaker. Thanks for joining us, Kwam. Over to you.
Well, thank you very much, Kate, for that introduction. No pressure, eh? And really thank you to the Vice Chancellor, Charlie Jeffrey, and it's really good to see such clear leadership on mental health, which is really, as you know, as a psychiatrist, I think is vitally important. Now, I'm really honoured to be here on the keynote, and I know that we've got 3 other fabulous speakers, and so I'm really looking forward to hearing them. And so I'm going to make sure that I try and keep to my time and not go into theirs, because I really like to hear the questions that you've got and have an interaction with them. And I'm going to speak to the title of this World Mental Health Day event, which is, mental health, another casualty of coronavirus, ? And I like the question mark because there are some things we take for granted, but things don't always work out exactly as they seem. So I'm going to start by sharing screens. And I'm hoping it's all working, because if not, we're in difficulty. Right, so I'm going to talk about 3 things pretty quickly. So for those of you who are old enough to remember Blue Peter, one I did earlier was one of the things they always used to say when they were making things, just in case they didn't work. So I'm going to talk about a previous study of the impacts of mental health on natural disaster, just to give you an idea of the way I think about this. I'm going to talk about what mental health impacts were actually expected in COVID. And because this is a fluid topic, and because it's very difficult to do comparisons between countries, I'm going to talk about what we found in Canada, but I'm going to hopefully use that as a way to bring out what we would expect in the UK. So I'm not going to start where you think I was going to start. I'm going to start actually 20 years ago to the week. And in autumn 2000, England and Wales experienced widespread flooding. And Lewis in southeast of England was one of the worst affected locations, and following multiple breaches of flood defences on the River Ouse at approximately 1 p.m. on Thursday, the 12th of October 2000, its town centre was completely flooded. Now, hundreds of people were stranded and had to be rescued by emergency services in boats. And by the time the flood waters started receding at 9:30 p.m, so it'd been flooded for a good 8 hours, some parts of Lewis were actually 3.6 metres under water. Now, there were no deaths by drowning or trauma. And actually, when they looked it up, they followed up, there were no increases in infectious diseases in the aftermath of the flood. But I was part of a team that went there 9 months later to do a case control study. And what we did is we compared people who were flooded, and they're the households in white. These are the areas, there are over 100, 200 houses that were part of the study, with non-flooded areas which were in black. And we did all of the things that you'd expect of trying to balance them on socioeconomic, by socioeconomic factors and by the age of the house and all of the things that you'd expect. And this is 9 months later, remember. And what we found, just looking at this slide, it's very technical, but really all you have to be able to see is that there is an increased risk of injuries, just about. Asthma got worse, increased rate of asthma getting worse, and increased rate of mental health problems. So that's what we found. And then we did an analysis to say, to see whether these things interacted. And what we found was the only thing that was positive 9 months later that we could definitely say that was positively related to the flooding was the fact that people had more depression. So general population, non-flooded, the rates of anxiety and depression were about 12%. But when you looked at the groups that were flooded, 48%. So 9 months later, you had a 50-50 chance of still being suffering from depression when the floods had only lasted 8 hours. The risk of mental health problems was in part because of the flood. It was in part because of the fact that people's possibilities and the trajectories of their lives had changed. This was a lot of people's, their house was their biggest asset, and actually trying to get a better job meant that you'd need to move, and you couldn't move, and your biggest asset was damage. And so the big model that we were creating was, it wasn't just the flood, it was the social context of the flood. It was what the flood meant, and it's what the flood meant for people's futures. And this is part of the things we have to think about when we're thinking about this bug. So people like to say we're in a war with COVID. We're not in a war with COVID. Being in a war with COVID is like being in a war with nature. It doesn't work very well and you always lose. COVID is just trying to survive. And the way it does that is by infecting us. It really doesn't want to kill us, but it's a new bug, it's poorly organized, and it's killing people. But it doesn't see us as individuals. COVID sees us as a society, and it needs to get into society so it can infect society so that it can replicate. And it does this through its weakest area, through society's weakest areas. It looks for the fracture lines in society, and then it gets in, and once it gets in, it replicates, and it looks, certainly in many societies, those fracture lines are race, age, gender, and disability. And that's how it gets in. Lots of people say that COVID exacerbates existing social problems. And one of the questions we have to ask ourselves is, why do we have existing social problems? If COVID's strategy is to enter via our most vulnerable and our weakest, the question is, why aren't we doing what we need to do to plug those gaps? Because that is the way of beating COVID. Now, we always, when we're thinking about how COVID might impact mental health, lots of people just think about the disease. But there are at least 4 ways that it's going to have an impact, that is expected to have an impact on mental health. The direct impacts of the disease, the actual impacts of public health measures, the impacts of decreased availability of medical care, and then the economic downturn. And we can go through these one at a time, and I'll do it relatively quickly. So the pandemic concerns could spark new mental distress. That's one way that it could lead to worse mental illness, or it could make a relapse of existing mental illness. And you'd be thinking about fear of getting COVID, fear of giving COVID to people, dealing with people who are ill, dealing with death and grief, or dealing with your own illness. COVID itself, because it infects all parts of the body, including the brain, could lead to some psychological illness. And there's some evidence that it does that. And COVID itself could produce neurological illness that leads to psychological illness. You'll know that one of the symptoms of COVID is losing your sense of smell. And actually, if you're losing your sense of smell, that usually means that you've got a minor encephalitis. So it's saying you've got a bit of brain swelling going on due to COVID. So we'd expect there'd be some direct mental health effects because of the illness itself. Then there are the impacts of the public health measures. And people think about isolation, they think of loneliness, they think of overcrowding, they think of increased levels of interpersonal and domestic violence due to isolation and social distancing, and people think of increased rates of substance misuse. All of those things you would think were parts of the public health response, but people don't talk about coherence, and coherence is important. And I'm going to say a little bit about coherence. If you want to feel comfortable and happy about what you're doing, you really need three things in place. The first thing, there needs to be a good plan. So you have to have a plan for what you're doing, or how you're going to get from A to B, say, for instance. And in a pandemic, you need a pandemic plan that makes sense. So it has to be a good plan. The next thing is you have to want to do it. So you have to actually not only think cognitively or yeah, this is a good plan, but it has to be something you want to do because you think it's important. Any of you who've got kids and you've decided you've got a great plan and you want to do something and the kids really don't want to do it, you know how miserable they're going to be. They may even agree with you that it's a good plan, but if they don't want to do it, it doesn't work. But the last thing is you have to have the resources, tools, skills, and support to work towards the plan. And this is where a lot of things fall down in our pandemic response. So people understand the plan. We've spent a lot of time making people scared of COVID. So a whole bunch of people want to work towards the plan because they think it's important. But then if we don't give people the right resources, say for instance, people are overcrowded so they can't socially isolate. Say we're telling to people that this is really important, but you really have to go to work on a crowded bus. Yeah. We say this is really important, you need to keep your kids at home, but we don't give people the right tools for them to homeschool. Or we say, everybody has to sacrifice, but we're not giving you enough money to pay for rent. All of these things mean that we don't have the coherence between what the plan is, what we want to do, and our ability to do it. And if we don't have coherence, we feel anxious and then we get depressed. And so there's in my mind, governments who decide to use pandemic plans and fear as a way of pushing forward a pandemic plan do actually have to think about giving people the tools, resources, skills, and supports to work towards a plan. Otherwise, it's predictable that there will be an increase in mental health problems. And one of the problems we've had worldwide is a lack of coherence in our government. The third way that we can get an increase in mental health problems is decreased access to medical care. And some of that can be because there are no face-to-face support. Some of it can be that the beds are not being used, but there are delays in treatment, interruption of treatment, access problems with digital mental health. But we must remember that there's also significantly through pandemics, often a loss of the city and charity sector supports, and loss of hard social supports like housing, jobs, and benefits. But one of the things we have seen certainly, and I think this has been seen worldwide, is there has been more focus on anxiety and chronic and common mental disorders, and a move away from schizophrenia with regards to care during the pandemic. And so we've seen more and more people with serious mental health problems relapsing. And then the last impact on mental health will be through the economic downturn. And this is the Canadian Medical Association's assessment of what makes you sick in Canada. And through their work, they are, and the Canadian Medical Association, by the way, is by no means a left-wing organisation at all. And they are saying 50% of what makes you sick is the social determinants of health, 10% is your environment, including civic structure and air quality, and 25% is your access to healthcare. So 85% of what makes you sick is a social environment and access to healthcare, and the economic downturn will increase the impact of these social determinants on your mental health. And so very clear why we would think that the economic downturn would lead to mental health problems, and financial insecurity is very, very linked to rates of depression and anxiety. But of course, it depends where you start. And this is one of the reasons why I'm not going to be talking about the UK so much, because the rates of mental health problems you get through a pandemic will depend on the rates of mental health problems before the pandemic. And austerity and inequity have significant impacts on mental health. And interesting that the UN rapporteur, after visiting various countries, including the UK, said that social justice may be more important than services in preventing mental health problems and also treating mental health problems. And so where you start is important, and the austerity of 12 years in the UK means that you're starting at a very different point in the pandemic a different point at the start of the pandemic than some other countries. It also depends on what you do. This is a difficult to see slide, but it doesn't matter because you're supposed to just be seeing the sizes of the boxes. And all this is looking at is wave 1. And it's looking at deaths from COVID in wave 1. And it is an analysis that says if a country had as good a pandemic response as Germany, as measured by death rates, how many lives would have been saved? And you can see that the United Kingdom, 35,864 deaths would have been prevented in wave 1 if the death rate was the same as Germany, if the pandemic response had been as good. And for those who are interested in the USA, that would have been 86,000 deaths saved in wave 1 alone. And it depends who you are. This is one of the comments from the UK government public inquiry into COVID and the Black and minority ethnic group sort of deaths. And it's a government and the UK government saying ethnicity and income inequality, both independently associated with COVID-19 mortality. Individuals from Black and ethnic minority groups more likely to work in occupations with higher risk of COVID-19, more likely to use public transportation, and then they say historic racism and poorer experience in healthcare. All work may mean that individuals in Black and minority ethnic groups are less likely to seek care when needed, or as NHS staff, less likely to speak up about the concerns they have about personal protective equipment. And it all sounds lovely until you realise that it seems like when you read this, the government in the UK takes no responsibility for disparities in COVID risk or COVID outcomes for the Black and minority ethnic groups. So concluding, And very quickly, you're going to see some graphs, because this is epidemiology, and so I have to show graphs. If I don't show graphs and say data, I haven't done my job. So just to start you realizing, Canada, centrist government, has an anti-poverty strategy which has decreased poverty by 28% in 3 years. But health and social care are provincial, and some provinces have been working in austerity times. And though we talk about Canada having a good response, the deaths in Canada are really down to 2 provinces, Ontario and Quebec. Many other provinces have had very, very good COVID responses with almost no deaths at all. At the start of COVID, there was a federal level response which gave anybody who'd lost a job about £3,000 sterling monthly, and told them that this would continue until the end of the first wave of the pandemic. The death rate in Canada is 4 times lower than in the UK, so the response has been pretty good. But 81% of the people who died were in long-term care. So what's happened for mental health? Looking at sort of general mental health and asking people from surveys, we find that good people saying or good or poor, poor or fair mental health, good, poor or fair mental health, that maps pretty well onto a GHQ score, a general health questionnaire score that would put you into a sort of a case level. And so it's been used a lot in Canada, and I'll just be presenting this sort of answers to these questions. And so from March, if you look to March to April to May, there's been a sort of a slight decrease in the number of people who say they have excellent or very good mental health by about 10%. What does that mean in terms of where we were pre-COVID? Well, on the left, we've got same data, but from a national survey that was done pre-COVID, and another one that was done post-COVID. So pre-COVID, about 26% said that their mental health was very good, and it's gone down to 17% by the time you get into the pandemic. Or if you add together very good and good, it's gone down from 67% to 53%. Same sort of sort of bar chart, but really looking at 2 groups and just during the pandemic, people who'd lost their job or lost significant hours of work versus people who haven't lost their job. And just as you'd expect, people who have not lost their job are more likely to have very good mental health than people who had lost their job. And then this last one is looking at people who are very concerned on the left compared to people who are not concerned at all really about COVID. And the people who are not concerned about COVID have much better mental health than the people who are very concerned, as you might expect. What you might not expect is the people with worse mental health are women between the ages of 18 and 54. So this is the group that we found over and over again who've had worse mental health impacts of COVID, and in Canada, worse than older people. So people 55 and over have maintained relatively good mental health, but women between the ages of 18 and 54 have not. And it's been different for different groups. So one of the nasty things that they have in Canada is a phrase called visible minorities, which is a horrible phrase, but it's what Statistics Canada use for Black and minority ethnic groups excluding Indigenous populations. And this is a study of 46,000 people across Canada between April and May of this year. And on the left, it's looking at people who have poor mental health in response to the survey, and the visible minorities are in grey and the white population are in white. So worse mental health for visible minorities. If you ask whether people, their mental health has deteriorated since physical distancing, not a big difference between white and visible minorities. But right on the right of this screen, it goes from the general discussion about whether your mental health is good to an actual measure of generalized anxiety. And the rates of generalized anxiety were high for everybody, but were higher for the visible minorities in grey compared to the white population. This gives a breakdown of the visible minority groups: South Asian, Chinese, Black, Filipino, Arab. All it really shows is whether it's fair or poor health, whether things have become much or worse since physical distancing. All the symptoms of generalized anxiety are not consistent, they are variable for the different place of origin groups. But the interesting thing is, if you look at this diagram, which is the proportion of participants who reported that their ability, that they had moderate or severe impact on their ability to meet financial obligations, this mirrors very closely the shape of the diagram around generalized anxiety. So, what is all of this telling us, and what can we make of it? So, we've seen that an increase in worry, an increase in poor mental health. Specifically, we've seen an increase in generalized anxiety on the rise. Mental health problems we found in Canada during COVID-19 are greatest for women and people who've lost their jobs, and in racialized groups. The problems seem to be increasing through wave one. The mental health impacts were predictable as expected, but our short-term solutions, such as income interventions, and we also had a temporary moratorium on evictions, didn't have as big an impact as we expected. And it's likely that more fundamental work needs to be done to decrease stress and worry because of a lack of coherence, and also because we're past, present, and future beings all at the same time. And people worry about the future. So unless there are fundamental supports in place that go into the future, people continue to worry. In thinking about that future, I would suggest that dealing with our mental health issues now are one of the best interventions and the most important interventions we could have for building back better. Thanks very much.
Thank you so much, Kwame, and we look forward to having you on the panel later. I'm going to move on to our series of speakers from the University of York, and the first of those is Dr. Umar Tosib, and Umar is a senior lecturer and director of the Child and Adolescent Neurodevelopmental Diversity Group in the Department of Education, and he's also the program leader for our Bachelor's of Science in Psychology and Education, and he's going to talk to us tonight about how COVID-19 is affecting the mental health of a particular group of children. Over to you, Umar, thanks.
Thank you, Kate. I'll be talking to you about the mental health of young people with special education needs and disabilities during COVID-19. I think we know that it would have affected these kids, but I'm hoping by the end of this talk, I'll just give you a flavour of the kinds of ways in which COVID has affected these families with vulnerable children. Okay, so what is special educational needs and disabilities? So a special educational need and disability is anything that affects a young person's ability to learn. In the UK, it affects about 15% of children who attend primary and secondary school. And most of those children go to some sort of mainstream school. There's a small minority, about 10%, who will attend a special school to address their specific needs. Now, on the right-hand side here, you'll see that there are four broad types of special educational need and disability that the UK government uses to define in schools. And I'll just go through them very quickly. So you've got cognition and learning, which is things like dyslexia, for example, or you've got communication and interaction, which are things like autism spectrum conditions. Then you've got sensory and physical needs. So it's those children with hearing impairment or visual impairment, Down syndrome, for example. And then you've got social, emotional, mental health difficulties. So a lot of these things co-occur. So for example, a child with autism might also have mental health difficulties. A child with dyslexia might also have autism. So there's a lot of co-occurrence between the different types of conditions. Those children with the most severe needs have something called an education healthcare plan, and that's a legally binding document where all the key stakeholders have a discussion about what kind of support will be helpful for children, for that specific child. And for example, a one-to-one teaching assistant, a speech and language therapist, occupational therapist, and those kinds of things. So when we were setting out to this project, we wanted to understand why mental health might be worse or better for these kids during lockdown. And we know that for the promotion of good mental health in young people, social relationships are important, friendships are important, networks are important, support's important. And for all of these kids, those with special educational needs, they tend to have poorer friendships, they're more likely to be bullied, low levels of self-esteem, all of which are risk factors for poor mental health in general. At the beginning of lockdown, children with special educational needs with an education healthcare plan were allowed to go to school, counted as vulnerable children, but very few did attend school. So about 10% at the beginning of lockdown, which so in middle of March, and then about a few months in, it got to about 18%. Parents were reluctant to send their children to school due to the risk of infection, but also because a lot of things had probably changed in school, which might be particularly distressing for the young people. So what did we do? At the beginning of lockdown, so since the first day of lockdown, we asked parents of children with special educational needs and disabilities to complete an online questionnaire about their experiences. And we did that at multiple time points. So in the first month of lockdown, in the second month of lockdown, in the third month of lockdown, and then we took a break over summer, and now just in the last 2 or 3 weeks or so, we've asked the parents to complete another questionnaire. At each of the time points, we tried to get new people involved in the study, but also follow some people up from the previous time points to see how things have changed. We had a broad range of conditions represented, but for the most part, about 3/4 of our sample had an autism spectrum condition, as well as other things as well. We had a range of age range represented, so between 5 to 18-year-olds is what we were going for. We had children who were verbal, who were able to use language to communicate, but also children who weren't verbal because of their special educational needs. And then we had a broad range of other types of demographics represented. I think it's particularly important here is to say we did have a high proportion of families who were from a low-income background, which we know have been affected in a disproportionate way by COVID in general. So what did we do? I'm just going to talk about the first month worth of data because we've got time for today. So in the first month, we asked parents, please describe in your own words how the coronavirus outbreak is affecting your mental health and your child's mental health. And parents had a free text box where they could just type in what they wanted and what they wanted to say. We took that text and we coded it in a number of different ways, and this is what we came up with. And I'm gonna talk a bit more about what these categories mean. So we had worry, loss, mood and emotions, behaviors, wanting to know what's going on, a feeling of being overwhelmed, and at the very end, I'll talk about a small group of parents who said that the lockdown had a minimal impact on their child and their family, or it had a positive effect So what did they mean by worry? Well, we're talking about excessive worry. So the child has excessive worry about themselves, about catching COVID, or worrying about others, so grandparents, parents, siblings, friends catching COVID, and also the parent being worried for the child. Now, I realize that a lot of families would have experienced worry in general, but I think it's particularly important here to think about the disproportionate levels of worry that some of these children might have experienced during those initial few months during COVID. I'm just going to read this out to you because I think it's particularly relevant. This is talking about the child. He's beside himself, constantly washing. He was off school the week before we were told to, as he was sure he was going to die. He was using hand sanitizer a day. Irrational thinking has become even more aggressive and curls up repeating, "I'm scared, I'm just scared." And this is the kind of thing that we were hearing from parents. And this is the kind of thing we're referring to when we say the child was excessively worried about catching COVID or the effects of COVID. The next point, group of responses that we got from parents was a sense of loss. So these families rely on a number of support networks, both formal and informal, to help care for their vulnerable children. So formal networks such as speech and language therapists, occupational therapists, one-to-one teaching support whilst in school, but also informal networks, parents, grandparents, siblings, friends. And if you can recall, at the beginning of lockdown, there was no mixing between households at all. So all of those support networks were cut off. Some of these children rely on very structured routines to help them get through and navigate life. And those routines were broken quite abruptly when lockdown was announced. Again, I'll just read out a particularly relevant quote here. So a lack of structure and the routine of school has meant that the child is more anxious, hyper, and lashing out. The child will not attempt schoolwork because home is for home and school is for school, and they do not mix. And I think, again, it represents the loss of routine about schoolwork being at school and home being for home, and not being able to make do and having a disruption there. There were significant changes to the child's mood, emotions, and behaviours. So a lot of parents expressed that the child was feeling particularly down and acting out, but also specifically behaviour change. So like I said earlier, some of these children are more likely to experience difficulties in general, but during this time, those difficulties are particularly pronounced. So I'll read another quote out for you. So my son is being more disruptive at home, wiping food into the carpet and all over the walls, breaking toys and ripping up books. And I suppose it represents a change in behaviour that we wouldn't necessarily expect to see in this kind of population, and partly because we, as parents and as people who support these children, we work with the children to figure ways to address these kinds of behaviours. But in a situation where that support has been broken, these kind of behaviours seem to have returned. Parents talked about being overwhelmed themselves because of the stress that they were experiencing and having to care for their child all day, every day. That's something that they've done before because of the additional needs that the child has. So I have felt completely unprepared for the reality of dealing with her 24/7 without any support or respite, as her behaviour is extremely challenging and she can become very physical. One of the things that we found was really interesting was the knowing what's going on had both a positive and a negative implication. So for those children who were able to understand what was going on, it served as a protective factor. So we are very fortunate that the child is very clever, and if you explain something in enough detail, they can really allay a lot of stresses. And that's really good because some children might not be able to understand, but the ones who are able to understand why we're doing what we're doing, it seemed to have a positive effect on their mental health and well-being. But on the other side, my daughter doesn't understand why she can't see her family, and that's made her feel quite sad and lonely, sometimes thinking it's a punishment for something she might have done. So not understanding why lockdown is happening, why we're not allowed to go and see other people, seemed to have a negative effect on these young people. And the final theme here is that some parents felt that being at home during lockdown seemed to have no effect on the mental health of their child, or even a positive effect. And if you think back to the beginning of the talk where I mentioned these children are more likely to be bullied at school, have poorer friendship, low levels of self-esteem, then being away from that in a supportive and safe environment may lead to a positive effect, and that's what we're seeing in some instances here. For example, his anxiety is much less than normal as he no longer has the daily torture of going to school. So we know some children with special educational needs find it difficult to engage with schoolwork, navigate school life, so not having to go through all of that might have had a positive effect on their anxiety levels. Very quickly on the responses that we've had in the last 2 weeks or so, it seems that the levels of anxiety have decreased since the beginning of lockdown, so since March in the child, and mood seems to have improved. We didn't have any pre-COVID measures, so we don't know whether it's returned to previous levels, but over the last 6 months or so, it does seem to be improving for the child. But for the parent themselves, there seems to be no change in their mental health and well-being. It doesn't seem to be getting worse, but it doesn't seem to be getting any better either. So in summary, many families with special educational needs and disabilities struggled with their mental health during lockdown. A minority didn't struggle and even found that for some of them, there was a positive effect. And since the schools have returned in September, some initial indications suggest that there have been some improvements in children's mental health, but not necessarily parents' mental health. And that's it from me. Thank you.
Thanks very much, Umar. Okay, our next speaker is Dr. Jane Suter. Jane is a lecturer in human resource management at the university, and she's joint head of the work management and organisation group in the York Management School. And she's currently the principal investigator for a multidisciplinary project looking at the impact of COVID-19 on employee mental health and well-being in small businesses. And that's what she's going to talk to us about this evening. Over to you, Jane.
Thank you very much, Kate. I'm just going to share my screen with you all now. So, good evening, everybody. I'm going to talk to you this evening about managing employee mental health and well-being in small businesses in our COVID-19 era. So, we currently have 12.8 million working days that were lost pre-pandemic in the UK due to work-related stress, depression and anxiety. And that's the equivalent of a loss to the economy of about £30 billion, as well as the hidden cost to people's lives. So there are low employment rates among people with severe mental illness, but many people with common mental health problems are in employment. And so it's vital that businesses are equipped to support these employees. During the COVID-19 pandemic, 5.6 million workers are at risk of losing their jobs, and the UK economy has been predicted to shrink by about 35%. So it's commonly understood that there are links between this financial hardship that we're probably going to see and mental illness, and it's clear that we're heading towards what Mind has called a mental health emergency. There's some research by the Centre for Mental Health, that reports that almost 1 in 5 adults have experienced some form of depression during the pandemic, and this has doubled from pre-pandemic estimates. So in our new ESRC funded research, we are going to examine the impact of COVID-19 on staff mental health and well-being in SMEs. So SMEs are small and medium enterprises. The small enterprises have between 1 and 49 employees, and medium enterprises are a bit bigger with between 50 and 250 employees. Now, our research draws on multidisciplinary expertise from management, primary care, mental health, psychiatry, social policy, and information visualization. And we're going to be exploring strategies and interventions and policies that will help SMEs support employee mental health. Now, this research was primed by a pre-pandemic study of small business managers' lived experiences of managing employees with mental health problems. And I'm going to talk a bit about what we're expecting to find from our research and also share some of the findings from our pilot study. So why are SMEs the focus of our research? Well, fundamentally, it's because they're significant both economically and socially. So you sometimes hear about SMEs being referred to as the backbone of our economy. There are 1.2 million small businesses, and SMEs account for about 3/5 of all employment in the UK. So this is a significant group of businesses. Importantly, though, for a post-COVID world, SMEs will be vital to economic growth and recovery, and there's evidence that SMEs can significantly contribute to broadening employment opportunities and to aid social inclusion. And so supporting SMEs, particularly small businesses, to better manage employee mental health is absolutely vital to the nation's recovery. So very briefly, what do we think the impact of COVID-19 will be on employee mental health? Well, the current crisis throws up a multiple number of challenges for both employers and employees. So for employees, they may need to do more with their jobs, particularly if part of that workforce is on furlough. They may need to learn new skills if they're redeployed. And all of this work intensification is going to lead to greater stress. For some workers, they might be anxious about physically coming to work, using public transport, or having to work whilst wearing a face covering. For those working from home, this has led to many of us maybe enjoying some of this new flexible working and maybe the freedom from our daily commute. But for others, working from home has led to feelings of isolation and loneliness. And many employees are reporting that they're working very odd or longer hours, and people may be less likely to switch off from work when the boundaries between work and home become more blurred, and this is going to lead to poor work-life balance. And alongside all of this, employees may be juggling work and care. So parents might be homeschooling or have emergency childcare. Parents might have less access to childcare, where they would usually rely on grandparents who are now shielding. And equally, many people are caring for elderly relatives, and they may be anxious about going to work and then exposing their loved ones to COVID. The poor outlook for the economy and uncertainty around jobs can lead to greater anxiety and poorer mental health. Employees might be worried about the possibility of redundancy, and where redundancies are made, there's often an impact on the mental health and well-being of redundancy survivors, so those who are remaining in work. And for many years, sickness absence was viewed as a significant problem for businesses when managing employees with poor mental health. However, our research has found that it's presenteeism that was viewed as a more significant problem for small business owners. So presenteeism is defined as working whilst unwell. And there are multiple factors that can encourage people to come to work when ill, which are evident during the pandemic. There might be fears over job security, social isolation, and digital presenteeism, where those working from home might find it harder to switch off and define clear boundaries between work and our home lives. So how do small businesses manage these issues? Does the nature of small businesses make mental health easier or more difficult to manage? And how do we support small businesses to manage mental health in the workplace? So the first thing we need to understand is why small businesses might be different to their larger counterparts. And small businesses, by their very nature, will have close social relations with people often very familiar with the entire workforce. This will include the senior managers, as there'll be very few layers in any hierarchy. Employment relations are likely to be informal and flexible, with a lack of formal policy and process. Related to this is a limited access to specialist expertise. So small businesses will not have access to occupational health, and the person who's responsible for HR is very often the owner manager themselves. And the bottom line, I think, for small businesses is that they have very limited resources, and their time and money is often spread very thinly. So a key question for me is, does this context matter when managing mental health? And there's a paradox here, as informal approaches to supporting employee mental health can be both positive and negative. So in our research, what worked well for the managers that we spoke to? And there were many benefits to the nature of a small business, and these included the values of the organisation. So, for example, family businesses, which treated their employees like members of the family. The visibility of the boss, particularly where the boss was open about their own mental health, and having an open, informal culture that allowed for two-way communication around the fluctuations in people's mental health and how this might relate to performance. We found that managers needed to take an individualised approach to what were often emergent mental health issues. We found that employer provision of flexibility in work hours and work location and workload to be important. And coupled to this, it really helped where there was an employee willingness to discuss their difficulties and also to take up the flexibilities and adjustments that were offered. And co-worker support, so the close working relationships in these small firms, could aid the support of employees with poor mental health. So here we have a quote from a small business owner highlighting how the values of the organisation and that intimate relationship with her workers was really important. So she said, I think it all comes down to being a small team. It's literally just me and my husband trying to build up a business. But we're not like cutthroat business people that just want to churn out staff to go and do this job. I really do care about the people that work for us. And in this next quote, our manager emphasises the informal cultures that are evident in many small organisations. I made a safe space for them to talk to me about their stuff. I think it's something about creating the right atmosphere and encouraging and welcoming disclosure when it came. And of course, managing employee mental health is not without its challenges, and these challenges are only going to get more significant, I think, with the impact of COVID on mental health. So for those employees who are working at home, mental health difficulties are likely to be harder to spot and more difficult to support. But I think the intimate nature of small businesses may mean that they're better positioned than larger organisations to spot these things and support it. Our research did suggest that while co-worker support could be helpful, the impact on co-workers in small businesses could also be significant. So being in a small workplace means that if someone is unable to perform well in their job, then the workload is redistributed to only a few people. Managers use the terms juggling or walking on a tightrope to describe how they navigated managing an employee through a period of poor mental health. And some managers found it difficult to disentangle the effects of an employee's mental health condition and general performance or conduct issues. And this could create a dilemma where whether performance management was a reasonable or legitimate approach. And finally, the mental load on owner managers themselves can be significant, with managers reporting that this juggling act could really affect their own mental health, particularly as they do not have access to the type of support that a larger or better resourced organisation might have. And finally, I'm going to end with a quote from one of our manager participants, which illustrates how small business owners often find the available guidance on managing employee mental health overwhelming and generic and prescriptive. So this manager said, there was nothing that was coherently useful. There wasn't any one particular resource that I thought, wow, yes, that's got everything, or even that's got 50%. There was lots of legal advice, there was lots of HR type advice. This is the right thing to do legally and employment-wise, these are your obligations, but there was nothing broader, nothing that made me think, yeah, okay, that's good, I'll follow that, other than being a decent human being. And that's a key question for our research moving forward, is how we can better support these small business managers to respond to the current mental health emergency. Thank you for listening.
Thanks very much, Jane. Thank you. And now our final speaker for the evening is Professor Simon Gilbody. He's given me permission to skip his rather lengthy introduction with all of his distinctions and awards and track record, just to say that Simon is a good friend and a colleague of mine and Professor of Psychological Medicine and Health Services Research in the Hull York Medical School and in the Department of Health Sciences at the university. Over to you, Simon.
Thank you, Kate. I want you to give me the thumbs up if you can see my screen just now.
Yep, I can. Yeah.
Thumbs up, that's great. So listen, we've had some super presentations so far, and one of the things that you might not have noticed is that we're seamlessly moving across the lifespan. So we now arrive with my final talk, which is thinking about how we might tackle a potential impact of COVID in the third age and amongst older people. So I've got my title there, so an ounce of prevention. So one of the things that we've been thinking about quite deeply over the past 10 years or so at the University of York is about how we might move from treating mental health conditions to thinking in a more upstream fashion and seeking to prevent the onset of mental ill health. And I'm going to talk about this with reference to a study that we're really quite proud of, and one that we've set up rather quickly in response to the COVID pandemic. And that's the BASIL trial. This is the first trial to be set up in the United Kingdom to mitigate the psychological impacts of COVID. And I know that I'm speaking to lots and lots of people today, so I'm not going to waste an opportunity there to put my Twitter handle up to see if I can pick up a few more followers. And feel free to say nice things or perhaps not so nice things about my talk as we go on. But I'm Simon Gilbody. I'm a population health scientist, but also a practicing psychiatrist. And I lead the Mental Health and Addictions Research Group here at the University of York. And we lead a large programme of work, some of which is around trials, using randomised controlled trials to understand what works so that we can seek to promote effective and efficient and equitable mental health in the population. So I'm going to talk and pick up about some of the themes that have emerged in some of the earlier talks today, and some of the themes in particular in Kwam's excellent presentation earlier on. I'm going to talk about this BASIL trial, but I'm going to think about COVID amongst older people and how this could potentially cause loneliness and the onset of depression, and think about how we might prevent the onset of depression and loneliness, in particular using very brief, scalable psychological interventions. And one that we've been researching over a number of years here at the University of York is one called behavioural activation. So I'll tell you a little bit about behavioural activation, what it is and why we think it was might be so useful in this situation. And I'll also give you an overview of how we've designed and delivered a large-scale trial in the face of all the challenges that COVID poses, and how we've worked with the NHS in delivering a large-scale trial in a relatively short period of time. So here I've got a visual representation of something that Kwam's already talked about, the different waves that we expect in response to COVID. And we've got the first wave there, the thing that's really put the NHS and society on high alert, this immediate threat of mortality and morbidity in the face of acute infections with COVID-19. So the first wave drove everything. And then there were downstream consequences of what happens when you completely repurpose the NHS to deal with a major societal threat from an epidemic. You get this second and third wave. It's what happens when the operations get cancelled, or the breast screening programme ceases to function, and or that when kids stop getting their immunisations. So we recognise these second and third waves, but ticking away in the background is this fourth wave, this slow burn of impacts that we might see in the population. And just thinking about some of the things that Kwam's already mentioned there, thinking about the psychic trauma amongst the population when lots and lots of people become unwell and die, the impacts for the NHS workforce, thinking and anticipating about the economic insults and the consequences that we know will follow from a downturn in the economy, thinking about burnout in the economic workforce, but a potential increase in rates of mental ill health in the broader population. So thinking about how we can influence and anticipate and potentially mitigate this fourth wave is something that we wanted to be at the part of here at the University of York. So this COVID fourth wave, we know that COVID has been deeply disruptive to people's lives. The very fact that we are talking here via Zoom when we would prefer to be in a lecture theatre in the University of York, inviting Kwame and taking him out for a nice meal after he's given you a great talk. You know, it's been so disruptive. But one of the things that we observe is the impact of COVID on social isolation, increased rates of social isolation, particularly for those who are shielding. And this is very disruptive to people's routines and those routines that keep as well. And when people socially isolate and start shielding, then they lose social contact. And we know that when you lose social contact, that's a risk factor for loneliness and for depression. And we know from research that precedes the COVID pandemic that depression and loneliness, and particularly when those two are together, are silent killers. And this is especially important for a population that we've been working with and thinking about for a number of years here at the University of York. And those are older people with long-term conditions. So, you know, we would anticipate that this might be the case. Emil Durkheim, the founding father of sociology, talks about social cohesion and connectedness and how this impacts on the health of populations, both physically and mentally. And most famously, Emil Durkheim would write about the impact of social cohesion on rates of suicide within populations. And if we were to look at some epidemiological evidence that predates the COVID pandemic, if we take groups of older people and think about the issues of social isolation and loneliness for those people, if you take 100 older people and ask them if they have experienced loneliness in the recent past, around 43% of older people were reporting the positive. And if we look at data from large epidemiological studies, we know that the presence of loneliness can substantially increase the risk of you dying prematurely. So it increases your rate of mortality. And people have calculated the health impacts of loneliness in terms of physical health, and someone has made the comparison there that the health impacts of loneliness are pretty much as bad as obesity, if not worse. And if you were to quantify that in terms of known health risks that you might see from smoking cigarettes, it has the health impact equivalent to smoking 15 cigarettes a day. So this isn't my term, but it has been said that loneliness is the new smoking. So this alerts us to the health impacts of loneliness. But what about the mental health impacts of loneliness? So we can see some of the headlines that have started to emerge around coronavirus. And in particular, it emerges that older people are particularly at risk. So, and this was helpful because we've been working in this area over the past few years, and we have existing research programs that seek to mitigate the impacts of loneliness and physical health problems on people's mental health. And it made us think that we might be able to make a contribution quite early on in the COVID pandemic, and we might be able to repurpose some of the existing research programs that were up and running but had stopped dead in their tracks once COVID hit the NHS. So we thought, well, what could we do? What could we do to appropriate some of the learning that we have to prevent the onset of mental illness amongst the older people who are particularly at risk of depression? So I used that term in my opening slide, an ounce of prevention. And it's a term that was first used by Benjamin Franklin, one of the founding fathers of the United States and the Declaration of Independence. He talks about an ounce of prevention being worth a pound of cure. And we've been thinking about prevention for a while, and we thought, how could we appropriate some of the work that we have already up and running? And so it's at this point I introduced the BASIL program, where we've taken an intervention we've been working on for a number of years, and we've trialed a number of times before and thought, how could we make that potentially work for older people who are shielding and socially isolated as a consequence of the COVID pandemic. So BASIL stands for Behavioural Activation in Social Isolation, and this is funded by the body that supports research in the National Health Service, and that's the National Institute for Health Research. So the basal intervention, what does that look like? Well, behavioural activation is the intervention that we use, and this is well grounded in psychological theory, and it's quite simple to deliver. And we have been training people to deliver behavioural activation for a number of years. And as COVID hit, we were just in the midst of writing manuals to deliver this intervention for older people with long-term conditions and were potentially isolated at home. So we very quickly appropriated these manuals that were already there, and we adapted them to enable people to receive this intervention under the circumstances of COVID. And the things that we sought to focus on from within the range of strategies that we use within behavioural activation is to reintroduce those things that we lose when we are socially isolating, to focus on maintaining people's social connection. And the neat thing we're able to do is to deliver this over the telephone. And we can train people to deliver this with a high level of competence after only 1 day of training. So if we can train people to deliver this with a minimal training component, then that is potentially something that we can deliver at scale. So we wanted to undertake a fair test of behavioural activation because there's no way in which we're going to scale this up unless we have robust evidence that it works. And the evidence that it works comes from randomised control trials. And I've put there 2 pink dice to remind me that this is a randomised control trial. And our homework question is, can we prevent depression and mitigate loneliness? And in order to answer this question, we need lots and lots of people. We need to recruit over 600 older people who are currently socially isolating or shielding and have long-term conditions. And the comparison that we make is between behavioural activation and some very general but sensible advice for older people about what they might do to try and keep themselves active. The sorts of things that are available on NHS websites. And according to the play of chance, people will either receive behavioural activation or this very general advice. So that's the comparison that we make. So we don't know the answer to that question just yet, but in order to get to where we are, we have gone from 0 to 60 in 3 months. We have designed and trained people to deliver the intervention within a trial, and we've started to go out and recruit people in this trial in a very short period of time. Within 3 months from having the idea, the first person was recruited, and it usually takes over 2 years to get to this point in a trial. One of the ways in which we've been able to do that is because we've got a great team, and we like it when a plan comes together. We've got a team here that we've assembled, great people who know how to deliver trials from the York Trials Unit, psychotherapists and psychologists that work amongst us, the people who know how to do the statistics, the epidemiologists and the health economists who know how to find out whether this is cost effective, and a group of people who can deliver this behavioural intervention over the telephone. So one of the ways in which we've been able to do this at scale and quite so rapidly is this has been adopted by a panel called the Urgent Public Health Panel, the panel that decides what the immediate research priorities are for the NHS during COVID. So this was the first trial of a psychological intervention to be adopted by the Urgent Public Health Panel. This is the same panel that enabled the NHS to answer that question about whether, for example, steroids were effective in saving people's lives if they experience very severe COVID. So this was approved and adopted by the Urgent Public Health Panel. And down in the corner there is someone who you don't see smiling very often. This is the Chief Medical Officer, Professor Chris Whitty. He usually has quite a serious look about him, but Chris Whitty, because this is on the Urgent Public Health Panel, receives a written summary as to how we are progressing with this trial once a week. And the trial's going really well. We've got past our pilot phase and we've ticked all the boxes in terms of our recruitment targets. So Chris is a happy man. So, so here's our question. Can we prevent and mitigate loneliness and depression for this population that's particularly at risk of the psychological impacts of COVID? And we don't know the answer yet, but we will know the answer within 6 months. So that's me. That is my presentation, and I shall now pass back to our distinguished chair, Professor Kate Pickett.
Thank you very much, Simon. Okay, I'd like to bring back all of our speakers for our panel. Can you all please, panelists, switch your videos and your microphones back on? Thanks so much for that interesting set of talks. We're running kind of close up to the hour. So audience members, we are actually going to run a little bit over, maybe to 5 past or 10 past, recognizing that some of you will have to leave us at the top of the hour. But if you can stay with us for our question and answer session, you're very welcome to do so. And so we will go a little past 8 o'clock. Panelists, thank you so much to all of you. We heard so many interesting perspectives, lots and lots of data. We've been gathering some questions from our audience, and so I'm going to try and pose some of them to you. And the first thing I'd ask you both all to respond to is, lots of people have been commenting on the great variety of responses we're seeing among people in relation to COVID. You know, children with special educational needs and disabilities, their mental health improving when they go back to school. You know, people asking, is that true for everybody? Is that true for kids without special educational needs and disabilities? Somebody commenting on how working at home, flexible working is working out really well for some and not for others. People commenting on how for women who've been juggling childcare and homeschooling, things have been different. Would any of you like to sort of comment on about the great variety? And to what extent do you think, panelists, we're going to get to a kind of new mental health normal? Economists keep talking about us getting into a new normal in the ways the economy is going to be working. What about a new normal for our mental health, our population mental health? Who'd like to go first? Just wave at me. All right, I'm going to pick one. Kwam, are we going to have a new normal? We'll go to Kwam and then to Simon.
Well, I think we definitely need a new normal, because the old normal wasn't working that well, quite honestly. I think that too many people were being left behind. And if there is a new normal to come out of this, it's the growing understanding that public policy and needs to think about mental health, and that our economy needs to think about mental health. But in answer to the question that was being put, I think that there will be different trajectories for different people during COVID, and different things will work for different people because it depends on what you need to be able to do what you need to do. This whole thing of coherence depends on what supports you need to make your life work. And it's not surprising that people with lots of demands on them, such as women, need more and different supports.
Simon.
So yeah, the new normal that I guess I would flag up is, you know, if we were to see an increased demand for care and input to try and mitigate some of the impacts of COVID, then that's probably not going to come from NHS mental health services. The NHS mental health services are really, really busy, and they were working at 110% before this hit us. So any strategy to respond to increased population needs of mental ill health has probably got to come from somewhere else other than NHS mental health services. So that's probably going to have to think probably more about prevention, probably more about psychosocial interventions as well, and the democratization of psychosocial interventions embedded within the things that Kwam has alluded to, and the things that you, Kate, would also be interested in, and that would be a recognition of the social determinants of mental health in the population, and also trying to anticipate what the mental health impacts are going to be from the economic downturn as well. So trying to mitigate the mental health consequences of increased rates of poverty and precarious housing will be the immediate ones for me.
Thanks. Umar, are there lessons for schools? You know, schools shut down completely, now they're back. how should schools be thinking about adapting and changing because of lessons learned from COVID?
Yeah, so I think I'll quickly talk about the differences, and then we can come on to the schools. I think in terms of whether young people without special educational needs are improving now that we're back at school, I mean, I would suspect that they are, but we don't have that data. But within the umbrella term of special educational needs and disabilities, there are a number of different conditions, so we would expect a lot of diversity within those. So for example, children with autism might be dealing with it a bit differently compared to children without autism. In terms of lessons for schools, I think what we've learned from some of our work and what we're hearing from other similar studies is about listening to parents and listening to the young people themselves. About how they would like to be supported, what kind of things are helpful when they come back to school, and what isn't helpful. So I suppose it's just listening to the young people and their parents and families about how they would like to be supported and what could be done to make school feel safer, but also have a less of a negative effect on their mental health.
Thanks. And Jane, a new normal in workplaces?
That's a really difficult one, isn't it? I think a new normal in workplaces are hopefully that employers will start responding to people's differences. I guess it is, or flexible working is about a choice. For some it works, for some working at home helps them, for others they prefer to be in the work. So an idea that actually one size doesn't fit all is, and that we've got to pay more attention to people's mental health and well-being is, I hope, what would be the new normal.
Thanks. Simon, a question for you about digital exclusion. Lots of older people are considered to be digitally excluded. Can you talk to us about how you're thinking about that in your research, and are you aware of programs to enhance digital inclusion for older people, particularly at this time?
So over the past few years, we have noticed a trend within health services, and that's a shift from face-to-face provision of mental health care to the provision of mental health interventions on computers and via apps. And that's great, but it doesn't work for everyone. One of the concerns that we have is that leaves behind certain sections of the population, and that can seek to amplify rather than minimise health inequalities and the health divide. And the health divide here is between those who are digitally connected and those who aren't. So that's a real worry. And the digital divide isn't democratic. It doesn't run uniformly right across the population. There are certain sections of the population that are potentially vulnerable to the digital divide. So people with severe mental ill health in particular might have less access to digitally provided mental health interventions, and older people. So this isn't true of all older people. Lots and lots of older people are digitally connected. So we worry about the whole-scale shift to NHS psychotherapy provision via computer and how that might discriminate against older people. So we thought about this quite deeply. So rather than put everything on an app or on a website, we've used an old-fashioned piece of technology, and that's the telephone. And we find that older people are quite happy to tell us lots and lots of things and to work in a therapeutic way and to engage really well using the telephone. So it's low-tech, distance-delivered psychological interventions that we tend to focus on for our population, and trying to keep things as low-tech as possible is one of our watchwords. So we've got materials that we print out and we mail out to people rather than sending them by email. And that works just fine. But if people want to receive things by email, that's also going to be an option if we were to think about scaling this up. So we assume that people aren't digitally connected, but we think if we find these things work, then the next question might be how you might digitally make those available for those that are connected. But don't assume that's the case. So the digital divide are really important and prescient problem for older people.
Simon. Jane, we have a question around how organisations can repair from the mental health costs of COVID-19. And, we had a public lecture at the university a couple of weeks ago from Naomi Klein. She was talking about how we can care and repair our economies and look after our planet and our people. How do you think organisations can care and repair for their workforces?
Well, I think they're going to have more open and two-way conversations with their employees about their mental health. I think there's going to have to be a lot of conversations about how we bring people back into the workplace. So people who've been working from home, how do we then make that transition back into the workplace? For people who are uncomfortable about coming into work, I think it's going to be a big issue. And then just how to train managers, line managers in how to have conversations around mental health and how to provide more flexible working workplaces and more adjustments in workplaces. So I think it's going to be a very, very challenging times ahead for them.
Thanks. Omar, there's a question from one of our audience members about what you think might be underpinning better mental health among some children during periods of lockdown and periods when they've not been in school. And I know that in our work in Bradford, you know, our research reveals very high levels of bullying in schools. What's COVID teaching us about the negative impact of some kinds of social relationships? And how can we move to ensure that we learn about the positive aspects of social connections, but we also recognize that for some people, other people, whether it's other children or family members or work colleagues, are not providing them with great social support?
Yeah, so I think that, like you said, there are some children who experience being bullied at school, and it seems to be a surprisingly large proportion of children who experience bullying or are the bullies at school. So being away from that environment might be the reason there's some respite for or improvement in mental health difficulties. But also, being at home might not have been that detrimental for some children because of the support network at home. They might have very close families, peers. In Bradford, for example, people might live as part of an extended family situation or multiple cousins, etc., who can form part of a peer support network. So there might be lower incidences of loneliness, for example. But also, I think what's important to think about is we hear a lot about peer bullying, so people at school bullying children, but also sibling bullying is quite prevalent as well. So being bullied in the home is a particular problem, and actually it's more prevalent than being bullied at school. And in my line of research, children with special educational needs and disabilities are more likely to be bullied at home and be involved in bullying at home. So yeah, the reason why some children might do better off is because they're away from bullying in school, but actually there may be some bullying at home that we should be thinking about too.
Thanks. Kwam, one of our audience members has asked about disturbed sleep and exhaustion and fatigue, and also physical symptoms that actually might be reflecting mental health problems. Are we seeing more of those kinds of somatic symptoms that are probably COVID related, that perhaps people are expressing where actually the underlying causes might be mental health conditions?
I think that there is, COVID is such a complex disease that yes, fatigue is one of the symptoms, and so there could be a, we could misclassify our fatigue for COVID when it might not be COVID. But then again, some people have found that worry and also depression also can present as fatigue. In fact, feeling tired and thinking too much are the two most common symptoms of depression worldwide. And so we've got an illness which causes fatigue. We've got depression, anxiety, which is on the rise, which causes fatigue. And we also have people changing their lifestyles and doing less exercise and doing a whole bunch of other things that are going to cause fatigue. And then we have people who are doing more things than they ever did, of juggling work and home life and staying up late in order to finish work because they have to look after the kids during the day, and that will cause fatigue. So it's not surprising that there's lots of fatigue out there, and some of it's COVID, some of it's depression, some of it's changed lifestyle. but for individuals, well, you have to try and work it out, speak to your family doctor and find out what your particular issues are and what can be done about it.
Thanks. Well, I don't want to add to anybody else's fatigue for the rest of the evening. I want to make sure everyone has time for enough sleep, and I'm afraid we have run out of time for questions. There's a lot of comments from the audience for all of you that they'd like to see you come back and present results of further research. They want to know the results of Simon's trial. They want to know how everything works out. So I hope we'll be able to welcome all of our speakers back to an event at the University of York to find out more about what you're all doing. But thank you all again very much, and thank you to all of you in the audience for taking part in this event and for all the terrific questions you raised. I'm sorry we didn't have time to answer all of them. Finally, a reminder about our Mentally Fit York campaign. A link to the campaign page will appear again in the chat box on your screen shortly, as soon as you've got rid of all of us. So thank you to our speakers. Thank you, Kwam, Simon, Umar, and Jane. Thank you to our organisers. Thank you to the Vice-Chancellor for presenting at the beginning. And thank you, all of you in the audience, for joining us tonight. I wish you all a very good night. One member of our audience did say, has anybody talked about kindness and the importance of being kind to one another for protecting our mental health? So I hope all of you go well, go and be kind to somebody. Good night.